The next paper is entitled Japanese Guidelines for Management of Neuroendocrine Tumors. The presenter is Dr. Masui from Kyoto University.
Thank you. It's my honor. It's my pleasure to be here and to be honored to have a presentation of our guidelines, our clinical practice guidelines for GEP-NET in Japan. I have no COI to disclose. Okay, let me introduce the history of NEN in the world and in Japan. In 1988, in 1888, Dr. Lubers in Germany reported intestinal NET, and in 1907, Dr. Obendorfer categorizes these tumors as slow-growing carcinoma-like tumors as named carcinoid. Around 100 years, the concept of the carcinoid developed, and in 2000, WHO 2000 2000 NET was defined in the WHO 2000. In 2005, NET was founded. In 2010, KIA67-based classification was presented in WHO 2010 with accumulation of survival data. In 2015, KIA67 and differentiation-based classification was proposed in WHO 2019. During this development, Japan Neuroendocrine Tumor Society was founded in 2012 by Dr. Imamura, and the first and the second edition of guidelines were published in 2015 and this autumn. Japan Neuroendocrine Tumor Society was founded in 2012 as an organization for doctors to engage in management of NEN patients. Members are 294 departments in institutions or hospitals in Japan. Our society is composed of many departments such as gastroenterology, endocrinology, oncology, thoracic surgery, HBP surgery, GI surgery, and radiology and pathology. And the member prevails from north to south in Japan. We have three missions. Our JNETS society has three missions. One is to hold annual meetings for prevalence of treatment of diagnostic updates. Second is to register NEN patients for elucidating the situation in Japan. And the last one is developing the Japanese guidelines for management of NEN. We have annual meetings every year around September. The 7th conference was held last September, and the agenda was harmonizing treatments of NEN in different primary sites. Our second mission is registration of NEN patients in Japan. The purpose of this registration is to achieve the NEN, analyze the NEN in Japan, and to produce evidences for guidelines. The registry began in 2015, and the registration number progressed steadily. The total number at the end of this July was 1,404. We are now analyzing data of these registered patients and developing additional studies from this study. And the third mission is to develop Japanese guidelines for NEN. It has been modified from the first edition this year and published by JNETS. There have been several guidelines for management of NEN from all over the world. For example, ENETS, NCCN, and NANETS presented guidelines for clinical management of NEN. Why do we need our guidelines? As in this slide, the number of NEN patients in the United States is increasing, especially pancreatic NEN is rapidly growing. As in the US, the number of GEP-NEN patients in Japan is increasing. From 2005 to 2010, pancreatic NEN patients per 100,000 population increased from 2.23 to 2.69. However, there are several differences in between Western countries and Japan. For example, about one-third of the primary site of GEP-NEN is ileum in Western countries, while only 3% in Japan. In addition, the hormonal syndrome such as flushing or diarrhea from ileal net is much less often in Japan comparing to those in Western countries. There are several limitations of tools that doctors in Japan can apply. In Japan, we can use indium DTPA SPECT CT, but cannot use gallium dot PET CT with national health insurance. Although, as in this slide, gallium dot PET can detect NEN with more specificity, with more high sensitivity. In addition, serial markers such as chromogranin A, pancreatic polypeptide, or VIP are not available in Japan. For treatment options, CAPTEM or PRRT is not covered by national health insurance in Japan. Because of this, we have developed our guidelines. GEP-NEN patients are comparatively rare but increasing in number also in Japan. And there are different characteristics of NEN from Western countries. And there are limited modalities compared to other countries. In 2015, we published first guidelines in Japan. As several new developments have occurred in the field of NEN in Japan after the publication of the first edition. First SRS was covered by health insurance in 2015. And in 2016, everolimus was approved into lung and gastrointestinal NET. Further, lanreotide somatostatin analog were to be covered by insurance. Finally, PRRT domestic clinical trial was launched in Japan in 2017 in patients with GEP-NETs. Under these developments in GEP-NETs in Japan, we aimed at publishing a revised edition as a second edition. We selected several opinions into recommendations by Delphi methods with several times of voting. The slide shows the contents of revised guideline. Guideline contains of 5 categories. In this presentation, I'm going to focus on the direction of surgical treatments in the guidelines, especially with regard to surgical indications of non-functional pancreatic NEC and for pancreatic NET G3. This slide shows the size distribution of PanNEN in Japan in 2005. At least in Japan, about half of the PanNENs are less than 2.0 centimeter in diameter. And the first edition of guideline recommended reduction for all of the non-functional PanNEN, even if those are with small size. However, in NCCN, observation is recommended in selected cases for local disease of non-functional tumors no more than 2 centimeters. The selected cases include less than 1 centimeter in diameter, low grade, incidentally discovered, high surgical risk. In ENET guidelines, the situation is the same. The surveillance is an option in cases with G1, low G2, asymptomatic, and so on for local regional disease for non-functional tumors no more than 2 centimeters. The slide shows the report of follow-up of non-functional PanNET less than 3 centimeters in diameter. The average follow-up period was 4.1 years. About 30% of the tumor reduced the size and 40% grows in diameter. However, the surveillance group and the resection after surveillance group showed the similar overall survivals, suggesting the allowance for observation. But from the point of the lymph node metastasis, PanNET might have a lymph node metastasis even with small size. This report represents the 12% of the tumor less than 1.0 centimeter had lymph node metastasis. And from 1.1 to 1 to 5% centimeter, about 14.3% of PanNET had lymph node metastasis. The small non-functional PanNET at our hospital in Japan had also lymph node metastasis less than 2 centimeters in diameter. This report presented 8% of the tumor from 1.1 to 1.5% had lymph node metastasis, and then 32% from 1.56 to 2.0 centimeters. From the analysis of overall survival in the United States, resection of small PanNEN contributes better survivals. This slide shows the analysis of PanNEN no more than 2 cm in diameter in NCDB database, and the left figure showed better survivals in resection. The right figure showed the overall survivals between resection and surveillance in tumors from 0 to 1 cm and presented statistically better in resection group in this category. Unfortunately, we don't have such kind of data in overall survivals in Japan. For these results, our guideline recommend a resection in all PanNET in principle, with additional comment in surveillance. We think that all the tumors should be resected oncologically, but the resection should be decided with risk and benefit. Another important issue is about the treatment of NETG3. The slide shows the revised WHO 2019 classification in digestive system tumors. The NETG3 was divided from NEC in the sense that it is a well-differentiated one. The classification of NETG3 and NEC is defined by differentiation from the pathological morphology, but additional genetic differences has been reported. This slide shows the genetic differences between NETG3 and NEC with immunohistochemical analysis. SSTR, ATRX, DAX were mutated in NETG3, while less in NEC. In contrast, RB1 deletion and P53 mutation were present around half of the NEC, but never in NETG3. This slide showed another report from genetic differences between NETG3 and NEC with immunohistochemical analysis in Japan. RB1 deletion and KRAS mutation were present around half of the NEC, but never in NETG3, indicating genetically different entity of tumors on NEC compared to NETG3, as previously reported. About surgical indication, we don't see much data about this category. This is a slide that shows that a retrospective analysis of surgical results of PanNETG3 and of PanNEC comparing to non-surgical treatment in Japan. In PanNETG3, patients with resection showed better overall survivals comparing to patients with non-surgical treatment. In contrast, PanNEC patients with resection showed similar overall survivals with those without resection. Although these are retrospective small number analysis, these two showed apparent differences. In the first edition of guidelines, there is no description about typical surgical treatment of NEC, resulting no guidance for surgeons. In the second edition, PanNETG3 patients are recommended to be treated under the strategy similar to the patients with NETG1 or NETG2, in which surgical resection is the first choice for treatment. Because the benefit of resection of NEC is not clear, no recommendation is proposed which permits resection or no resection treatment for NEC. One more change for surgical management is to move the metastatic NEN at the surgical management section to the medical and multidisciplinary management section. The aim of this is to emphasize the concept that surgery is a part of the multidisciplinary treatment for the tumors with metastatic, because surgical therapy rarely provides cures. The benefit of the resection of metastatic tumors are reported to be apparent. The slide compares surgical resection with local treatment for liver metastasis neuroendocrine tumors with the propensity score matching. And the surgical resection contributed better overall survivals. However, many manuscripts about the progression-free survivals after resection reported 100% recurrence sooner or later. The left figure shows recurrence of all the resected tumors patients within record within 7 years, and the right figure shows the resection prolonged progression-free survival compared to R1 resection, but record within 10 years. From these results, the guidelines recommend resection at first if the curative resection is expected, but this multidisciplinary treatment is necessary. In contrast, no recommendation is proposed for GEP-NEC because of a few clear evidences. For metastatic tumors, the guidelines covers from total local therapy, symptom relief, and to the tumor control, pharmacological therapy, and radiation that we can utilize at present in Japan for NEC and for NEC. In summary, we still recommend the resection of small PanNEC and PanNET, and emphasize the importance of discriminating NETG3 from NET. We also presented the importance of multidisciplinary treatment to GEP-NEC with metastasis. We hope this revised guidelines could be a guide for doctors engaged in management of NEN patients in Japan. Thank you for your kind attention.
So in the revision, did you actually expand your plan to resect small neuroendocrine tumors? Is that what I understood?
Yes, we tried to, but initially we don't have any alternatives such as observation for small tumors, but we have oncologically we think so, but we have to decide. We have to decide and compare between the benefit and risk of the surgery. So, as you said, we try to expand the observation target.
It's a great talk. I just want to publicly commend you for starting an organization in your country that is advocating and changing the standard of care for patients with this disease. It's really remarkable, so congratulations.
Thank you very much.
For reporting on it.